Same disclosures. I'm going to discuss biliary imaging with focusing on techniques and interpretation of MRCP and some fitballs. We'll talk about some ancillary techniques, including hepatobiliary agents and the use of secretin MRCP. As you know, this was described years ago by Wallner. Now it's the test of choice. Here's a nice example of an MRCP. How do we do the MRCPs? Well, it's basically fluid-sensitive techniques. So we're going to be using T2-weighted images. We use a combination of a variety of techniques. Certainly, we use the thin-slice single-shot techniques, depending on your vendor. We use a thick slab rare technique often, but it's important, as I'll illustrate, to look at the thin slices. We also use the either navigator-triggered or some people use respiratory-triggered MRCP with MIP images to get beautiful images. And here's an illustration. This is that rare technique depending on your vendor, but it's basically a thick slab MRCP. The nice thing about this is it's a single breath hold. You get 2 to 6 centimeter coverages. It only takes about 3 to 5 seconds. You can get multiple planes, and you get a nice cholangiogram. It's not as exquisite sometimes as some of the 3D techniques, but certainly the referring doctors like it. You can't manipulate them afterwards. And how do we do that? We typically will have the technologist do a variety. We don't do as many as like some institutions, but we have them do several oblique planes through the common duct as well as the pancreatic duct to ensure that we get a nice MRCP. This is the more Rolls-Royce version where you get a 3D MRCP, a 1 millimeter slice thickness. You can even use compressed sense to save some time to get higher resolution or faster images. Obviously, this is great for talks, but we don't routinely do a movie and all that kind of stuff. But this nicely illustrates cystic duct, the aberrant right hepatic duct, and the pancreatic duct nicely. And you can see the differences in quality. So this is the rare versus the 3D MRCP, but this takes several minutes, so it's certainly longer. What about contrast use? Well, IV contrast use is not routinely required if you're looking at stones and MRCP. We often use it because we want to look at the liver, bile ducts, and the pancreas. And we'll talk about later the use of gatoxetate or EVIS for biliary excretion. Generally, we don't administer oral contrast, although more recently we started to do it similar to Mayo, where we do it for the secretin MRCP, but we're starting to use negative contrast more routinely. And for that, we use gadolinium mixed with water. You can also use, in the past, gastromark or blueberry juice. It got to be a little bit difficult to store the blueberry juice and other things, but we use it for secretin studies where we give oral contrast with GAD and water. You can also make the bowel bright if you want using water or other techniques, but generally we want the bowel to be dark. We also use secretin, as I mentioned, to look at pancreatic secretion, and we're doing more and more of these studies for our referring doctors. And you can look at the pancreatic duct and look at pancreatic function. For biliary obstruction, certainly our workhorse, and we routinely use ultrasound and CT for initial screening, but then we often will use MR if we're worried about a common duct stone not seen on ultrasound or CT. As I'll illustrate, if you're thinking of a tumor, then obviously it's important to use gadolinium. And then also if you're looking for intrahepatic and extrinsic causes of biliary obstruction, then gadolinium can be helpful. So with the T2 MRCP, it's interesting. The stones you usually think are going to be like a round ball. They're actually like this, where they're faceted. And with MR, we get a very high sensitivity. I'd like to think we're 100%, but we certainly aren't. It's been quoted as 89 to 100%, and the specificity, similar ranges, but it's comparable to ERCP and obviously has the advantage of not being invasive. And it's better than ultrasound and CT, with CT and ultrasound certainly getting better with dual energy CT. But MR if you're really worried. And the stones, as I mentioned, are low signal intensity. They're dependent in the duct. They often have these geometric or angular shapes. Some of the smaller MRCP stones we may miss. Here's a typical patient where you have a patient with gallstone pancreatitis, where the patient has some gallstones, has pancreatitis. On the CT, you might hallucinate some stones, but in this case, it was very difficult to see the presence of stones. The reason I show this is because you don't want to just rely on your MRCP images. If you just look at our MIP image, we don't see any stones, but obviously what you need to do is you need to look at your source images. You look at the coronal thin haze as well as the source images for the MRCP, and you can see numerous tiny stones that are dependently within the duct. Now, as I mentioned, with dual energy CT, a lot of the people aren't aware of it, but you see biliary obstruction, you have a contrast enhanced CT. Now I start to look more and more at the virtual non-con or the low KEV images, and if you look really closely, you can see the presence of a stone here. Iodine map, it's not enhancing because obviously it's not a mass or tumor. Maritzi's is a unique form of gallstones, which you have to be aware of. What happens is you get an impacted stone in the cystic duct or the neck of the gallbladder, and what it does is it causes obstruction upstream into the intrahepatic and common duct. And the reason it's important is the surgeons have to be aware of it before surgery, and it's not going to be cleared on the basis of an ERCP, so it's important for surgical planning, can lead to jaundice and cholangitis, and whether you're doing CT, MR, or ultrasound, you want to look for the stone in the cystic duct or gallbladder or neck. Another example, this is just to illustrate, just because you see a filling defect, don't assume that it's a stone. So you can see that this low signal intensity, but then when you look at the source images, what you find out is that these filling defects is actually due to pneumobilia or air in the duct. As you would expect, air is seen non-dependently or more anterior in location, and it can also limit your evaluation for the presence of stones as well. A few other pitfalls I want to talk about besides I'm going to illustrate, but pneumobilia is seen in the setting of biliary enteric anastomosis, biliary stents, and sphincterotomy. We want to look at the in-phase images because that's more, shows the gas the best. It has a higher sensitivity than our standard sequences because what you see is a susceptibility artifact better seen on the gradient echo images and the longer TE due to continued decay of transverse magnetization. But you can see here, it looks like a stone on the conventional imaging, but notice how dark and dephasing there is on the in phase, and that's from the presence of air. And in fact, air is a lot more easily seen on CT, and I find it not infrequently where the air within the intrahepatic ducts will be hard to appreciate on the MR, and sometimes it's called biliary obstruction. But when you look really closely, you can see the presence of air, and especially on the in-phase images because of dephasing. And then the reason I'm showing the ultrasound is the same issue. When you look at the ultrasound, you actually get dirty shadowing, not to be mistaken for calcifications. Other pitfalls, this is referred to as a pseudocalculus sign. The nice thing about MR is you get numerous images. If you just look at these images, you think that there's a stone in the distal duct. There's certainly abrupt termination. But the nice thing is if you wait long enough, you'll see that it's actually due to sphincter of Oddi contraction, mimicking a stone or a stricture. It's referred to as a pseudocalculus sign. And the key feature is that it's transient. Other pitfalls is when we first started doing this, I had to reach out to friends to figure out what it was. But what you end up seeing on the thin section haste images or single shot fast spin echo images in the center of the duct, you see this low signal intensity abnormality. We don't have to routinely do TrueFist, but this just nicely illustrates that you don't see it on the TrueFist images. And why is that? It's because it's flow related. So it's seen non-dependently. It's seen in the middle of the duct, especially on the thin slices. Another important pitfall is this one. I've seen it not infrequently called elsewhere, sometimes a stricture, and you can see why, because there's a gap here. But then what you notice is when you look closely, it's often the hepatic artery that's crossing at that level, and it's actually due to pulsation artifact. And it's important not to think that this is due to cholangiocarcinoma or due to a stricture. This is a 49-year-old gentleman, hit abnormal LFTs, right upper quadrant pain. There's a large filling defect, but notice the large filling defect isn't as dark as you might see typically with a stone. This is a less common case, but it does illustrate an important finding. In this particular case, if you give gadolinium, you can see that it's clearly enhancing, and you can see on the ERCP that there's a big mass, and this actually was a cholangiocarcinoma. Another example, obviously if I'm giving a talk, I'm showing less common things, but it's important for you to realize, here's another filling defect on the T2. It looks like it's a stone, but notice there's some subtle enhancement. How do I know there's subtle enhancement? Because you can do subtraction images, and by doing the subtraction images, it nicely illustrates the presence of enhancement. The other thing is, if you look at the diffusion images, obviously if it was a stone, it's not going to restrict diffusion. So you can see in this particular case, it's bright on the high B value image, dark on the ADC. They did an EUS, and this actually was an unusual entity. It was a neuroendocrine tumor with ampullary adenocarcinoma components mimicking a stone. And I thought the diffusion was certainly helpful. This is an entity that I've only more recently become aware of, maybe in the last 5 to 10 years. This is intraductal papillary mucinous neoplasm of the bile duct. I had shown you IPMNs of the pancreas, but these are thought to have a higher malignant potential, and they're precursor to cholangiocarcinoma, and it's something that we should be aware of. What it is an intraductal papillary proliferation of neoplastic cells along a fibrovascular core. And they can have a variable appearance. It depends on the amount of mucin, it depends on the amount of biliary dilatation and mass component. Again, it can be difficult to see the underlying mass because of the presence of mucin. There's something referred to as a thread sign, which is mucin within the markedly dilated duct. Here you can see it looks just like, in some cases like this one, it looks just like cholangiocarcinoma. There's a filling defect in this case. On the ERCP, you see the filling defect. On the EUS, you can see that it's a solid mass. In this case, it was due to an IPNB, but the important thing is to recognize that it's not due to, obviously, a stone. And on pathology, this was confirmed to be an IPNB. I have other cases that look identical to this, where it's a cholangiocarcinoma arising within an IPNB. This was a case that one of my fellows this year, who was a fellow from a couple of years ago, sent me. It nicely illustrates, you see the duct dilatation, and then when you look really closely, what do we see? We see a filling defect that's enhancing. This actually, based on that, he made the correct diagnosis. It too was an IPNB. So basically, it's the mucin being produced by this papillary projection. So it's important to diagnose because these are surgical lesions. Now we'll just talk about the different types of cholangiocarcinoma. There's hilar cholangiocarcinoma, which is the one we're all aware of, which is the Klatskin tumor, tends to occur at the confluence of the right and left hepatic ducts. MRCP can also be quite useful because it shows the extended biliary obstruction. So here's the MRCP. You see that there's a big gap as a result of a tumor. And when you look really closely, then you start to see that there's a solid mass. It can be very subtle, as illustrated here, where you see subtle delayed enhancement due to the presence of a tumor. Your clue is that you have the separation of the bile ducts, so you have to look for an underlying mass. And in fact, on diffusion, if you look closely in this case, you can see that there's restricted diffusion, as you would expect. The other types of cholangio include the extrahepatic cholangio. So this nicely illustrates one form of the extrahepatic cholangio where we can see that there's a stricture, and it's a long stricture. It's fairly subtle, but when you look closely, you can see that there's a low signal abnormality involving the bile duct with some abnormal increased enhancement. And as a result of this stricture and the suspicion of cholangiocarcinoma, they did an ERCP and biopsy and came up with a diagnosis of cholangio. Here, it's a lot easier when you see the presence of a liver met associated with it, but again, this was due to cholangiocarcinoma involving the extrahepatic bile duct. You can also have what's referred to as intrahepatic cholangiocarcinomas. Sometimes these look like adenocarcinomas because they're peripheral, but as illustrated here, sometimes you'll get biliary obstruction and dilatation, and you see delayed enhancement as you would expect in the presence of cholangiocarcinoma. And then you can, again, I think I'm showing you my only few movies, but you can obtain a 3D MRCP, and you could beautifully see the presence of the intrahepatic biliary dilatation, the presence of a tight stricture, as illustrated here, so you know that there's something going on. This is somebody with cholangiocarcinoma, a Klatskin tumor. One thing you might not be aware of, you could do the MRCP, you could see the presence of a suspected mass. You do the post-GAD images, beautifully illustrates the presence of the cholangiocarcinoma, but sometimes you could see nicely the presence of peritoneal implants on the MRI based on all this omental soft tissue enhancing. This is a polypoid cholangio, looks similar to, as we talked about before, the IPNB, but you see this filling defect, which is low signal intensity. When you look closely, you can see that in fact it's enhancing and restricting diffusion. And here's the ERCP, and this is the pathology image nicely illustrating what we suspected, which was that this was concerning for cholangio. I'm going to briefly talk about the different cholangitis. I can't talk about all of them, obviously, but I'm going to talk about recurrent pyogenic cholangitis, primary sclerosing cholangitis, IgG4-related sclerosing cholangitis, because we've been seeing a lot of that recently, and then COVID cholangiopathy, given the presence of COVID. So recurrent pyogenic cholangitis is the one you learn about in med school. That's the one that has the pigmented stones, so sometimes they're bright on T1, they're hyperdense on CT, they may not always be obstructive. They're classically due to clonorchis and ascariasis. They're more common in Southeast Asia as well as from immigrants from those countries. And what happens is you get chronic inflammation that causes the biliary stricture and stasis and intraductal stone formation. And unfortunately, there's an increased risk of cholangiocarcinoma in up to 5% of the population. Here you can see that biliary dilatation. When you look closely, a lot of times you'll see these pigmented stones as bright on T1, and there'll be the vanishing duct sign where you don't even see the duct at all due to the obstruction. Sclerosing cholangitis, we do MRs, as I'm sure you guys do as well, on a daily basis with patients with sclerosing cholangitis because they no longer do ERCPs as much on every patient. So this is strongly associated with inflammatory bowel disease, ulcerative colitis. What do we look for? We see the diffuse bile duct wall thickening. We see the abnormal enhancement. We see beading, referring to the multifocal strictures with intervening normal or mildly dilated ducts. We may see what's called a prune tree appearance, which is basically obliteration of the peripheral ducts with long segments of dilated ducts without any visible side branches. Here too, you might get bile duct stones. It can also be T1 hyperintense, mimicking the recurrent pyogenic cholangitis. This is patients with PSC are predisposed to cholangitis, cirrhosis, and cholangiocarcinoma. So again, we use MRCP for non-invasive diagnosis and monitoring these patients. And generally, we use ERCP if we want to either stent them or for sampling and getting a tissue diagnosis. So these are two different examples. You can see the biliary dilatation. You can see how subtle sometimes the enhancing mass is, as illustrated here. Another example with biliary obstruction, and again with the presence of an enhancing mass. As I mentioned, PSC is a pre-malignant condition. There's a 10 to 20% lifetime risk for cholangiocarcinomas. In the past, we used to call these dominant strictures, but now the preferred term is calling them either high-grade or low-grade strictures with significant upstream dilatation to consider cholangiocarcinoma. If you see a rapid progression of duct dilatation, you can sometimes suggest the presence of cholangiocarcinoma even before a mass appears. So if I see a rapid progression duct dilatation, these are the patients that I would send to ERCP. And in later stages, you certainly can sometimes see a ductal mass with delayed enhancement, as I had illustrated here. IgG4-related sclerosing cholangitis or cholangiopathy, I want you to be aware of. It's an important diagnosis, and as a radiologist, we're often the first one to suggest it. It's IgG4-related disease. We're all used to it from autoimmune pancreatitis, but you can also get a sclerosing cholangitis. And I've seen a few patients where they came in with a diagnosis of many years of sclerosing cholangitis, and I see abnormality in other organs, and I suggest this diagnosis. So what do you look for? You see biliary strictures with thickening and enhancement of the bile duct wall. But that's when I start to look at other organs. So in this particular case, I might see autoimmune pancreatitis, that sausage-shaped appearance to the pancreas with a low-density rim. I look for retroperitoneal fibrosis. And I start to look at the kidney because it's interesting. In the kidney, you can see hypoenhancing lesions, whether it's CT or MR, and they're often low signal intensity on T2 weighted images. And it's important to diagnose because these patients respond to steroids, and these patients generally don't develop cholangio. So here's an example, it looks like PSC almost, but then all of a sudden we see that there's pancreatic duct disease where there's a stricture, there's exuberant thickening of the common bile duct, and again, there's that sausage-shaped appearance on the CT scan as illustrated here. In fact, there's also retroperitoneal fibrosis and low signal intensity lesions involving the kidney. So this illustrates IgG4-related cholangitis, and this patient, I don't think, had a known diagnosis of that, and they had done an ERCP as well. What about COVID cholangiopathy? Well, I've only seen, I think, this case and another one we suggested it, but basically it's a secondary sclerosing cholangitis, and the diagnosis is based on the clinical laboratory and imaging findings because the imaging appearance, as you can see here, is similar to other types of sclerosing cholangitis or secondary cholangiopathies. What did we see? We see multifocal strictures. We can see some edema on T2, some abnormal enhancement, and some thickening of the bile duct wall in a patient who had COVID. What about biliary hamartomas? Why am I showing this in a biliary talk? The reason I'm showing this is because sometimes you get all these little high signal intensity foci, and people want to think that it's Caroli's disease or something else, but in fact it's due to biliary hamartomas, which is very common. So if you see small cystic lesions in the liver, less than 1 centimeter, it's often not just hepatic cysts, but it's biliary hamartomas. Ultrasound, it's interesting, they are often echogenic, and this is from failed involution of the biliary precursors during embryogenesis, and it's manifested as these multiple cystic lesions, as I illustrated here. The MRCP of the biliary tree is normal. There's no duct dilatation or communication with the hamartomas, but you do have to be careful because it can look like it's a biliary disease, but the lack of communication is your clue. This brings me to congenital bile duct cysts, and I probably could talk for half an hour just on the bile duct cysts, but I want you to at least be aware of it. They're not that common, but you do see them. The classic triad is jaundice, abdominal pain, and palpable mass, but unfortunately that's not seen that commonly in adults. So as a radiologist, we can be the one to suspect it and to diagnose it. And it's important because some of the forms they need to resect because of the associated malignancy, ascending cholangitis, and stone formation, as I'll show you. And as radiologists, we can assess the location and the length of involvement, which is important in planning surgery. This is going to come out in a radiographics article that I'd written, but basically there's a variety of types of choledochal cysts. Some people even think that the type 5 and some of these are not really choledochal cysts, but needless to say, these present in childhood, the majority, but we are seeing them not infrequently in adults. And your clue sometimes, in my opinion, is if you see marked duct dilatation and you don't see a cause. So if I start to see a duct that's over 1 centimeter, for example, it's less commonly seen in the setting of biliary obstruction, especially if it's a younger female. And MRCP can be helpful because it can show the cyst morphology, it can show the pancreatic biliary junction, which we'll talk about, as well as the complications associated with it. Here is the Tadani classification. I'm not going to go into a lot of detail other than say there's 3 types of type 1 cyst, depending on how the cyst itself looks. Type 2 is probably the least common, where there's actually a diverticulum coming off the common bile duct. Type 3 is the choledococele. Type 4 is when it has intra and extrahepatic involvement. Similarly, that's divided into 4A and 4B. And then type 5, as we'll talk about, is the Caroli's disease. And again, I don't think you have to memorize this. I think Perry had alluded to it nicely with the internal hernias. I think as long as you're descriptive, and then you can always obviously look up which type it applies to. So again, here's just a nice schematic, and this will be out in radiographics. But there's other articles that have it too, obviously. So the first thing I do is when I see that there's massive duct dilatation in the common bile duct, for example, I start to look what's referred to as anomalous pancreatic biliary junction, which is basically a common channel of the pancreatic duct and the distal common bile duct, as illustrated here. Depends what you read. Somewhere places that say a centimeter, centimeter and a half, but it occurs in a large percentage of this type 1 choledochal cyst, and sometimes it's hard to see it, and sometimes they have to do an ERCP to confirm it. But if you look closely, sometimes you'll see it. And it's associated, as I mentioned, with choledochal cysts, stones, and even malignancy, including gallbladder cancer and cholangiocarcinoma. Type 1, as I mentioned before, can be divided into A, B, and C. I'm not going to go into all the details, but if you start to see this fusiform dilatation, then you start to consider choledochal cysts, certainly. And these are the ones you want to diagnose because of the higher risk of malignancy, and a lot of them should be resected, although they don't resect all of them at my institution. But the key thing is to refer it to the right person, a hepatobiliary surgeon or a hepatologist or with specialty with this area. This is just to illustrate one of the examples. This is a type 4A, and why do I say that? Because you can see these fusiform dilatation of the intrahepatic ducts as well as fusiform dilatation of the common duct. And you're not going to see this dilatation in the setting of obstruction generally. What are the complications of choledochal cysts? Well, biliary stones, as I'll show you, are certainly one of them. Cholangitis is the other, but the one we always worry about is malignancy, and the incidence of malignancy can be variable, but around 10 to 30% depending on the type. And it's typically cholangiocarcinoma, but also can be in the setting of gallbladder cancer. More commonly in that type 1, that fusiform dilatation, the 4A, and the Caroli's disease. Choledococele or choledochal diverticulum rarely are associated, or essentially the the diverticulum has no significant association with malignancy. So, but What I've also noticed is that we underdiagnose choledococele. So to give you an example, is that when you look at the CT, if you start to see this cystic abnormality at the level of the ampulla, you want to look closely and you want to suggest possibility of a choledococele. And in this case, it nicely illustrates actually presence of multiple tiny stones within the choledococele from stasis. And you can see that on the ERCP as well, where you see these filling defects from choledococele with stones. Another example, this was a fortunate individual. This was, well, maybe not fortunate, but fortunate to get imaging because she's a 48-year-old woman, alcohol abuse, epigastric pain. This is, over a centimeter and a half dilatation, probably 2 centimeters. But what was interesting here is this is what you learn about in school. This is somebody who had an actual small polypoid mass with some flow in it. We did an MR, and you can see the filling defect. You can see that the filling defect, in fact, is enhancing. So this actually was a small adenocarcinoma or cholangiocarcinoma arising in a choledococele cyst, And the reason I say she's lucky because they ended up doing surgery and resecting it before it had spread. Corolles is the one we learn about as well. This is autosomal recessive with segmental intrahepatic biliary dilatation. What you want to look for here is what's referred to as the central dot sign, where you see this area of enhancement. And basically what that is it's either the portal vein classically or the hepatic artery surrounded with dilated duct to differentiate it from hepatic cysts or, as I mentioned before, von Meyenberg or biliary hamartomas. Corolles is the one that's associated with renal abnormalities, whether it's medullary sponge disease or autosomal dominant polycystic kidney disease. Let's talk about functional MRCP. You got hepatobiliary contrast agents and secretin. As I mentioned before, T2 is our go-to, but you can also use hepatobiliary agents. And again, classically, we use GAD-EOB because of the higher biliary excretion. We want to increase the flip angle to 35 or 40 degrees. This was a great call by one of my colleagues. You see a cystic lesion in the area of the porta hepatis. And the question was, is this communicating or not communicating with the bile duct? So we did our conventional MRCP. And I was reading this and I couldn't tell. I mean, I thought it was probably communicating, but wasn't entirely sure. So what did I do? I had them administer gadoxetate or Eovist, and it beautifully shows the communication. And this is the very uncommon one that I talked about. I've only seen a few times, which is the type 2 choledochal cyst or diverticule. And you could get beautiful images, contrast-enhanced images to show that as well with a higher flip angle. This is a post-cholecystectomy. They were worried about a biliary leak. There's certainly the clips from the surgery. There's some fluid. On the conventional MR, you certainly would suspect it based on the appearance of the fluid. It looks like it's in an abnormal location. But in this particular case, it was an easy diagnosis once you give the Eovist, and it shows the communication from a bioleak. And I think sometimes it's better than a HIDA scan in showing that. And they did an ERCP and showed and confirmed the presence of the leak. Secretin, as I mentioned, some places used to do it. I don't know if they still do routinely. It's a bit expensive and more time-consuming. We use it selectively. We do it to look at the pancreatic duct a little bit better, but especially to look for leaks or pancreatic function. As I alluded to, we use negative contrast in the stomach to get rid of the contrast. And then we image them with that rare sequence every 30 to 60 seconds for a total of 10 minutes, and then we get a 3D sequence afterwards. And usually you see the maximum effects early in 7 to 10 minutes. And why do we do that? Well, here's a normal secretin exam. The pancreatic duct dilates a little bit, but more importantly, in my opinion, is you start to see visualization of the duodenum to the level of the jejunum. So this is normal function of the following secretin. And there's a nice AJR article on this as well. Here's somebody with chronic pancreatitis, and the reason I'm showing this is you can see the abnormality. There's no visualization or filling of the small bowel, and so there's poor exocrine function, as I illustrated. This was a 43-year-old man with mild chronic pancreatic insufficiency. The difference here is you're only seeing a small portion of the duodenum filling, so this was considered grade 2. So in conclusion, as I mentioned, I think MRCP is the best technique to non-invasively evaluate the biliary and pancreatic duct. The quality of the images are constantly improving, and there's newer functional imaging techniques to consider, including secretin MRCP and GAD-EOB biliary imaging. And thank you.